everybody. My name is Satara Banisatter, and I'm a lupus patient and longtime volunteer for the Lupus Foundation. I'd like to welcome you all today to today's conference on behalf of the Lupus Foundation of Northern California. We have an exciting conference planned today, but before we begin, I'd like to let you know about a few things that the LFNC has coming up. As many of you know, May is Lupus Awareness Month, and you can help raise awareness by checking out LFNC's website at lfnc.org/lupusawareness. This is where you'll find different ways to help bring awareness to lupus. We will be sharing stories and videos from lupus patients throughout the month, so please be sure to follow our social media on Facebook, Instagram, or X. We are also getting our June Health Conference finalized, so be sure to watch for some posts and emails to find out who will be presenting and when. Lastly, don't forget to sign up for the 30th Annual Outrun Lupus 5K. We would love to have a big turnout for our 30th, and early bird pricing is available through the end of May. So you can sign up at outrunlupus.org. We have a packed schedule today, so I will be going over the agenda quickly, and then we'll go ahead and get started. Our first session, we're welcoming back Dr. C. Michael Newwelt, and he will be giving us an update on lupus in 2024. In our second session, we will be hearing from 3 lupus patients in our patient panel. The patient panel will not be recorded for privacy reasons. Each of our sessions will end with a 15-minute Q&A, and remember, you can ask your questions at any time. We will be gathering the questions and asking them after the appropriate presentation. You can also ask your question anonymously by clicking the anonymous button. Now I'd love to introduce Dr. C. Michael Newell. Dr. Newell has been challenged and fascinated by SLE since 1973 during his 3rd year in medical school. This challenge and interest has persisted throughout his 43 years in clinical practice, which began in 1979. Dr. Newell participated in subcutaneous belimumab trials and ongoing belimumab plus standard of care treatment in lupus nephritis. In addition to his interest in research, he continues to see patients in his private practice and has not lost his passion for diagnosing and treating complicated lupus patients. Welcome back, Dr. Newell.
Well, thank you very much. It's a pleasure to be here. And as I put this talk together for 2024, I felt like, hey, this is exciting because I can build on what I presented last year. And I can only say, I just want to sort of make an anecdotal statement of what happens now in my practice. I had a lot of patients that I was sort of at a standstill because I had used all the tools in my box. Some FDA indicated, mostly not FDA indicated. And then all of a sudden, we came out with biological drugs that are intended specifically for lupus. And I think that they've made a big difference. And now I can say there are so many patients that I see, they come in and I say, you know, was this drug started? Was that drug started? And they say, oh, Dr. Newell, I've never felt better. This is the best drug you've ever given me. My fatigue is better, arthritis and skin. So it's an exciting time. You don't want to have lupus, but if you do have lupus, we can do a much better job of making you feel better. Yeah. So let's get started here. First slide. And if you could go back, yeah, to the title slide, please.
Oh, I apologize.
Yeah, and so I'm going to talk about lab and clinical presentation. I'm going to talk about things that can trigger lupus because we're learning more and more about that. And I will spend some time talking about some of the new drugs that I mentioned last year. And on this title slide, only one thing is different. If you look at the bottom, it says update 2024, and it's nice to have new information in 2024 rather than the old information that we always had. Next slide, please. So there are numerous factors that cause lupus and organ damage. And we're learning a lot more about genetic susceptibility, which is immune mediated. We know about stimuli from the environment, hormones, and infection. And I'm going to talk a little bit about hormones because I think we're learning more about that. And these are things that we use. And there's been more studies looking at this. And I think it's kind of exciting. So the genetic and the stimuli, we get autoimmune amplification, we get things called autoantibodies, and consequently, it leads to disease. Now, how about sex hormones in SLE? Next slide, please. Now, estrogen and progesterone flare rate is 40 to 75 to 70% in pregnancies. Can flare each month with menstruation with estrogen-containing oral and postmental hormone therapy. So it can flare the disease. I'm always asked about this, and I tell them, yes, it can flare. Hormone replacement therapy are associated with a risk of flare. And the frequency and severity of flare in most postmenopausal women with SLE decrease. So I do tell people, and since I've been doing this a long time, I have patients who, when I first saw them, they were just starting their menstrual period. They had children, which was relevant, and now they're in menopause. And I think the age makes a difference in the effect that sex hormones can have. Next slide, please. So here's a group of studies, hormone replacement therapy and SLE flares. And as you can look at this, people tried to do it in a more case-controlled manner. And the first three here on this table showed that there wasn't any flare. But on the bottom, a case report of a 64-year-old woman showed that there was a flare taking estrogen for osteoporosis. Next slide. And here are some other studies where they show flares. And I would say what I tell patients is that, we don't know the exact answer, but I think every patient is different. And I think we have to decide about what their lupus has and the kind of problems they have. Next slide, please. So what is the conclusion of all this? As you can see, there's conflicting results on the use of oral contraceptives, hormone replacement therapy, and their use raises the risk of flares or cardiovascular diseases in some of the patients. Antiphospholipid antibodies, if they have a history of thrombosis, are important. Therefore, hormone therapy for patients with SLE should be decided through close consultation. And as I go through this, I would say most patients elect, if they're thinking about starting it, don't start it. But, there is evidence that it won't flare their disease. So it's sort of an individual decision between doctor and patient. Next slide. Now, how about heredity in lupus? And if a patient has lupus, there's a 1 in 40 chance that her daughter might have lupus, and 1 out of 250 if she has a son. I showed this slide last year, but it's nice and simple, and it gives you that relationship of heredity, and certainly showing that women have a higher incidence, 10 to 1. Next slide. How about epigenetics? And if you summarize everything, probably occurs from a genetic predisposition in 2/3 of the risk and environmental in 1/3. Now, what are some of the environmental risk factors? A lot of literature on Epstein-Barr virus, CMV, silica exposure, pesticides, and the gut microbiome. Now, the risk in the general population is 1 in 1,000 in white females. Now, if you have an identical twin, there can be up to a half a chance of that patient having lupus. In non-identical twins, it's only 2 to 5%. And first-degree relatives have a 6-fold higher risk and more likely to be ANA positive. Now, that's really important because it can save a lot of time, because a lot of patients that get referred to me have a positive ANA. Now, if it's not 1 to 40 or 1 to 80, and 1 to 40 is what they might send, then I say, well, you know, we really need 1 to 80 for it to be significant. But I ask them if they have a family history of lupus, and they say that they do. And if they do, as I said, there's a 6-fold higher risk of having a positive ANA. They don't have anything to suggest lupus. So basically, that's a good thing to remember if maybe your family or someone in your family has lupus and all you have is the ANA. That can happen, and unless you have the signs and symptoms of lupus, which I'll go over in the classification criteria, you don't have to worry. Next slide. So epigenetics is caused by external or environmental factors that switch genes on and off. And in SLE, the DNA in African Americans make their T cells more pro-inflammatory and more active compared to other populations. And that might be one of the explanations why lupus is higher in African Americans. Next slide, please. Now, these are the criteria that we currently use, and it involves clinical domains and blood tests. So when you look at the clinical domains, if someone has a fever, that counts as 2 points. If they have cutaneous involvement, and let's say they have multiple skin involvement, you only pick one out of this category, the one that has the highest number. So if they have acute cutaneous lupus, that would count as 2. And if they had non-scarring alopecia, you wouldn't score that because you can only do 1. And if they have arthritis in it, at least, swelling, inflammation, or tenderness in at least 2 joints, that counts as a 6. In neurological, we break it down to more specific things: delirium, psychosis, seizures. And seizures can count as 5, but you got to remember a lot of things can cause seizures. And we only score these if there's not another factor that could explain it. Now, for serositis, which could be inflammation of the lungs or the heart, if they have a pleural or pericardial effusion, that counts as a 5. Or if they have acute pericarditis, fluid around the heart, that counts as 6. If they have low white counts, thrombocytopenia, or autoimmune hemolytic anemia, especially with a positive Coombs, they score as 4. And then for the kidneys, if they have more than 500 milligrams of protein in 24 hours, or if on biopsy they have class 2 or 4, 2 or 5, or a class 3 or 4. The blood tests include the anti-phospholipid antibody test. So consequently, I order those in the beginning. Now, they may have no history of having clots or having miscarriages, but those are criteria. The other advantage of doing that is, if you're wondering if someone has the anti-phospholipid antibody syndrome, you like to get 2 sets 6 weeks apart, and you already have a baseline of blood tests. The other one is complement, whether it's low C3 or 4, or both of them. And then the highly specific autoantibody score is 6, is DNA and Smith. Now, you have to have at least 10 or higher to meet the criteria. The ANA has to be 1 to 80. And it's only scored if there is no other likely cause. And as I told you, in each clinical criterion or lab, only the highest criterion scores. And SLE classification requires points from at least one clinical domain. So you can't have everything over here. You have to have something clinically. Now, again, this is a very good way. And they say, well, these are classification criteria. But actually, as we do this more and more, and we have more patients we're diagnosing with lupus and we have newer drugs, most rheumatologists or lupologists like myself use this as a diagnosis in the clinic because it's very good and very helpful. Next slide, please. Now, you got to remember what other conditions are associated with a positive ANA. Well, in lupus, it's 99 to 100%. In drug-induced lupus, it's 100%, and they have the antihistone antibody. You also see it a lot in scleroderma, less frequently in polymyositis, dermatomyositis. In Sjogren's, 40 to 80%. In the phospholipid syndrome, almost half. Rheumatoid arthritis, 30 to 50%. And then you can also see it in other inflammatory conditions. Autoimmune liver disease, it's 100%. Thyroid, multiple sclerosis, primary pulmonary hypertension, chronic infections such as TB, monobacterial endocarditis, and 15 to 25% in cancer patients, especially lymphoma. Next slide. Now, can ANA be detected in the normal population? Yes. And up to 20 to 30% of healthy individuals have a positive ANA at 1 to 40. And I remember 1 to 40 doesn't really get me saying, oh, I bet you have lupus. And certainly 70% of people older than 70 can get an ANA. As we get to 1 to 80, which is what we use clinically, we also use that in our trials that we do. That's the minimum. 1 to 160 is 5%, 1 to 320 is 3%, and healthy relatives, as we've talked before, is 5 to 25%. I always like to talk about the ANA because I think it's important, and I don't want people to worry if they have a positive ANA, but it's a low titer, or they have family members that have lupus. They have to have that clinical findings before we can say, yes, you have lupus. Next slide, please. Now, the autoantibodies are key and are almost present in most patients. And there's amplification of the immune system, both innate and adaptive, and pathways that recruit inflammatory cells. So on the left, you see the autoantibodies. And if you look at the ANA, at the onset, it's only 76%. So you might see a patient that has a lot of clinical features, but 24% may not have a positive ANA. If you look at it at any time, it's 94%. Now, the double-stranded DNA, which is much more specific, leads to a lot of confusion because it's only present at onset at 34%, at any time during the disease, 71%. So a negative DNA doesn't mean you don't have lupus as long as you meet other criteria. Next slide. And here are some of the diseases. The double-stranded DNA has a lot of specificity. It's present 70 to 80%. And it's important because that's how we can pick up people that may feel pretty good, but they have kidney disease. And you look at their urine, there's an active sediment, they're spilling protein. We also see it in skin disease. The nucleosome is present in 60 to 90, and that's also present kidney and skin. Now, the Rho is present in kidney, skin, and anyone that has Rho or La, which is SSA or SSB, this is a little different. So if I have a lupus patient and they have positive antibodies, I know that these antibodies can cross the placenta and lead to fetal heart problems. And if they do, I tell them to go to a high-risk OB, and many times what they might have to do is have a cardiologist there to treat the heart block. So that's important. The Smith, that's not smooth muscle, but Smith, little lower, 10 to 30% for kidney disease, and the phospholipids, 20 to 30, but these people can have thrombosis. If it's thrombosis in the patient, they have to be anticoagulated, or they have pregnancy loss. And if they've had miscarriages and they have phospholipid antibodies, we tend to put them on anticoagulants, not Coumadin, but other like Lovenox during their pregnancy and 6 weeks after to prevent problems. And then we have the actinin and C1q, both associated with kidney disease. Next slide, please. Now, there's a lot of variability in clinical presentation and can result in difficulty in diagnosis. And almost half the patients with a presumptive diagnosis of SLE and are referred to an autoimmune lupus center have other diagnoses. Now, on the left here, you see a lupus patient. You can see the malar rash over the nose and the cheeks, but notice it also affects the nasolabial folds. Now, with rosacea, it sometimes can look like a lupus rash, okay? And it can look a little bit different, all right? Next slide. Now, look at the different manifestations of the rash, photosensitivity, arthritis, seizures, and you can see whether Hispanic, African American, or Caucasian, there's different percent of patients. But usually when you look at it, and especially if you look at a young African American patient, they're more likely to have lupus than other people. So what I teach residents that work here and learn rheumatology, if I see a young African American female and she tells me that she's been having joint pain and rash, I ask about any hair fall, and I notice they either have a hat or a wig. And I ask them, could you please take your hat off or your wig? And many times what I'll see is really severe alopecia, diffusely or focal, with scarring of the scalp. And I think I'll show you a picture of that. But that lets me know, yeah, this patient has lupus. Next slide, please. Now, this is a very important slide. The rate of mortality remains high relative to the general population. Now, I'm going to go right to left. If you look at somebody greater than 60, it's only a little bit greater because people with over that age have a lot of normal risk factors for having cardiovascular disease, whether it be myocardial infarction, arrhythmias, etc. Then when you get 40 to 59, there's more. When you get 25 to 39, it's 8 times the risk. And then when you get young people, 16 to 24, it's getting close to 20% more, because most people this age do not have signs or symptoms of cardiovascular disease. So consequently, a young patient that I'm following that comes in and says, oh, I got chest pressure. It feels like somebody's sitting on my chest, or they say, I think my heart is beating funny. I take that very seriously, and I send them to a cardiologist to rule out any significant cardiovascular disease. And that's one of the reasons why lupus patients are living longer, because we understand the disease better, and we send them to the right kind of specialist to make sure we're not missing something. Next slide. Now, how about non-specific manifestations of lupus, which I think are important because they can help you make the diagnosis because they're there, but they're not part of that classification criteria. There's fever, and I think most of you would know if a patient has fever, the first thing I think about is infection. It's about the first 9 things I think about. And I want to look at the white count. Lupus patients, when it's active, they can lose weight. They can have fatigue, and fatigue is a tough one. But I have to say, it's not as bad as it was with some of these new biological drugs. They have myalgias. They can have associated fibromyalgia. Now, one of the problems I also see is people that have fibromyalgia, doctors don't look to see, well, maybe they have underlying lupus. They can get enlarged lymph nodes. I see your arrow there. And they also can have Raynaud's phenomenon. Let's go to the next slide. And here is another example of a patient with a butterfly rash. And if you notice very red on the cheeks, but spares the nasolabial folds. Next slide. And here's an African American that has discoid, and this leads to damage. There's no hair growth in those areas. And these kind of people, we want to pick up early and we want to treat them. And I think we have better treatment for that now, because I think the new biological drugs are very good for skin treatment. Next slide. And here you can see a lupus patient with an oral ulcer on the top of the mouth, and she has a ulceration on her lip. Next slide. And here is an African-American patient. Now, this patient would probably come in and not have a hat on or a wig, but this patient that comes in would probably have on a hat or a wig. And I asked them, and I've never had a patient refuse me because I ask it in a very nice, gentle way. And I take off their hat and I see this. This is damage. There, the skin has been damaged by lupus and will not grow back. Now, we want to prevent further damage by treating this, but we have to be realistic, or this patient is put in a clinical trial. We have to make it clear where there's still hair and not hair, because no matter what we do, there's been damage to the hair follicle with inflammation, and that hair won't grow back. Next slide. And here's a patient that has swelling of her PIP joints, and one might think, hey, this is rheumatoid arthritis, because some people don't realize that lupus can cause arthritis. And many times it's called a Jacquard's arthropathy, Jaccouds, because they have inflammation, but it's reducible. And here's a patient with lupus. One might think that's rheumatoid, but these deformities are reducible because the inflammation is in the soft tissue and tendons and not in the cartilage. So in both of these patients, and you can see here, this patient looks like she had a procedure on her MCP joints, but these are reducible deformities. Next slide. Now, the CNS is a very difficult area. I spent a lot of time with this in the past and had a lot of observational papers, but we've never been able to come up with a good randomized controlled trial because there's so many different features. We call it neuropsychiatric lupus, and they can have diffuse manifestations. They can have psychiatric manifestations, but that's a toughie, because if they're depressed, it's hard to say the depression is caused by lupus as opposed to dealing with this disease. They can have trouble thinking, cognitive impairment, which sometimes can lead to almost dementia. And a lot of these patients with significant cognitive impairment, I get neuropsych testing. So the neuropsychologist can tell me how significant this is. They can have seizures, and you have to rule out other causes of seizures. Headache is another one that's tough because there's a lot of people that have migraine headaches that don't have CNS lupus. They can have focal manifestations. If they have focal manifestations like transient ischemic attacks, and there's little demyelinating areas on the brain MRI, that might suggest that they have the antiphospholipid antibody syndrome. And in those people, we want to put them on anticoagulants. And as I go back to what I said in the beginning, I certainly wouldn't want those people on estrogen-containing products. And then there can be the peripheral nervous system, and they can get various forms of neuropathy. Next slide. And in the heart, this is a very important area that we've really picked up on in the last 5 to 10 years. They can have pericarditis, which is fluid around the heart. They can have inflammation of the heart muscle, which can lead to congestive heart failure. They have a higher incidence of hypertension, although hypertension could be coming from renal involvement. And then you look at the kidneys and they have proteinuria and active cells, and that could lead to high blood pressure. And remember, a lot of patients, we're talking about younger patients, and it's unusual for younger patients to have significant hypertension. They can have inflammation of their coronary arteries. They can have inflammation in the valves, and that for years has been called Lipid-Sachs endocarditis. They can have that, and that can lead to valvular insufficiency. And now we have techniques where if it's significant, we sometimes can replace the valve by an endoscopic procedure. TAVR, you see advertisements for this on television. You see advertisements for a lot of the drugs I'm going to talk about on television. Now, a lupus patient has a 7 to 10 times increased risk of coronary heart disease and stroke. And that's why I showed you previously that young people with lupus, I take anything they say that might be cardiovascular seriously, and many times I send them to a cardiologist. Next slide. Now, this is something that we've known for a while. And I think I mentioned this last year, and it's important enough that I'm going to mention it here this year. In the inflammatory state, the HDLs, which are normally protective, become pro-inflammatory. And in the presence of pro-inflammatory HDL, there's an 8 to 10 times increased risk of atherosclerosis. And we know atherosclerosis can lead to cardiovascular disease, heart attack, stroke. In rheumatoid arthritis, it's similar, but it's only 5-fold, it's half. And in lupus patients with atherosclerosis, 90% have pro-inflammatory HDLs. So if they have this, it's likely in the future to be a good measure of propensity to develop the atherosclerosis dependent on absolute lipid values. So I get lipid values and I treat those very aggressively in these types of patients. And if you look in the bottom right, pro-inflammatory HDL, you can see in the lupus group, almost 45%, RA 20%. And then in a control group, it's only 4%. So this is a very important concept. It's almost like having lupus is another risk factor for cardiovascular disease and atherosclerosis. Next slide. Now, how about the lungs? And these patients can get pleurisy. When I ask them, when they take a deep breath, do they get chest pain? It's not on the outside, like they have costochondritis, it's on the inside. And by the classification criteria, they either have to have an abnormal chest x-ray, echocardiogram, or you hear a rub. You can get a pneumonitis, which, hey, that could look like an infection. And remember, the other thing is, I always think about infection first when I evaluate lupus patients. They can get pulmonary hemorrhage, and that's very serious. And I gave a lecture on Wednesday to the residents, and I explained that pulmonary hemorrhage is a rheumatological emergency because many times these patients need plasmapheresis. As it goes on, they can get fibrosis. They can get a shrinking lung syndrome, which takes aggressive management. They can get pulmonary embolus or in situ thrombosis. And of course, all of you out there know in those patients, I'll make sure I check the phospholipid antibody. And then they also can get pulmonary hypertension. But now we have drugs that can help treat that. Some are biological, some are vasodilators. So we're coming a long way in treating these things. And I think a lupus patient that has shortness of breath, and you get an echo and they have a large right ventricle and their pulmonary artery pressure is high, we many times do a cath to see if they'll respond to some of the medications we have. Next slide. And here's an example of a pleural effusion, which you see here, and occurs in 30% of patients during their course. Many times it's asymptomatic. It can present as chest pain, shortness of breath. They usually can get a small amount of fluid you see on the x-ray. If you tap it, the white cells are less than 10,000, and you see lots of polymorph cells and lymphs. Next slide, please. Now, we're getting into a different area now with lupus and the kidney. And we have now 2 new drugs that can help us treat the kidneys, which I'll talk about pretty soon. So the amount of renal damage can predict renal failure. And 5 to 10% of lupus patients progress to end-stage renal disease. So when I see patients, I make sure I tell them, no, you have mild lupus. You have arthritis, skin, and I don't see any evidence that you have anything in your kidneys. And in one study, 25% of patients with early renal damage versus 7.3 without early damage died within 10 years of initial assessment. And here you can, on the right, you see a red cell cath. So I look at their urine very carefully to make sure they don't have those red cell caths. I make sure we get their blood pressure. I make sure they don't have edema, which would mean that maybe they have proteinuria. And we would see that on the urinalysis. And I would get a protein to creatinine ratio, because many times these patients don't have other manifestations and they feel pretty good. So you have to make sure you go after it and try to figure out if they do have lupus in the kidney. And as we pick it up earlier, we may treat them, we get a renal biopsy, and we have lots of choices in how to treat them, which I'll show you later. Next slide. Now, here you can see the different manifestations of lupus. And I can see, you see a positive ANA, 97%. So 3% don't. Arthritis, skin, joint muscle pain, complements, DNA, low white count, pleurisy, protein in the urine, anemia, cardiolipid antibodies, CNS, and you can see all the way down. And the CNS disease that I talked about only occurs in 1/3 of the patients. Next slide. Now, we're going to go now to treatment, okay? And treatment, for many years, we borrowed drugs from other specialties. And we're going to go mild to moderate. Arthritis, fever, pleurisy, pericarditis, fluid around the heart, cutaneous. The big thing I tell them 2 things. Make sure you use sunscreen. They can use non-steroidal anti-inflammatory drugs as long as their kidneys are okay. They can use corticosteroids, but usually if I use that, 5 milligrams twice a day, and I almost always also put them on Plaquenil, because that's a very good drug to control disease. It also helps prevent cardiovascular disease. If they have arthritis, I think about methotrexate or leflunomide, which is Arava. I don't use that much thalidomide. I use lots of antimalarials, topicals, especially sunscreen, hydrocortisone cream. Never use more than 1% hydrocortisone cream on the face, and things like physical therapy. Next slide. Now, this is Bill Murray, and he was in a movie with Scarlett Johansson, and lupus for many years was lost in translation. These people were lonely. He looks lonely. He couldn't sleep. But all of a sudden, there was culture shock. And there was 51 years of waiting. But we finally found a new drug for lupus, which was a biological drug, which has been now around almost 13 years. And in this city, things have gone from the bench to the bedside. So he doesn't have to sit at the bed. We can do things at the bedside for these patients. And that is the exciting thing. We have more tools in our toolbox that we can use to treat these patients. Next slide, please. So let's talk about the current standard of therapy. Now, I showed this slide last year, but I'm going to build on it with more we know about the recently approved drugs and some that we're working on. So if people have moderate to severe disease, now this is a little different. Nephritis, I told you, and I showed you the morbidity, mortality, vasculitis, which could be very serious, pneumonitis, which can be look like a bad pneumonia, but it can lead to pulmonary hemorrhage or shrinking lung. Central nervous system can be very serious, and some of the blood disorders with very low platelets, and patients with lupus can get something called TTP, thrombotic thrombocytopenia purpura, and these take more aggressive management. So what's our treatment? If you look, almost all patients with lupus, I've already started them on hydroxychloroquine. Now we have to be a little more careful because as we look at the data, the total dose and what can lead to retinal toxicity, we tend to bring the hydroxychloroquine dose down or stop it. Now, a person like me, who in August will have been in practice 45 years, I'm very aware of that because I have people that have been on it a long time. And most people, I get them down to a lower dose, 7 milligrams per kilogram a day. Usually it's 1.5. We have cyclophosphamide, which has been around a long time, which we use. There's azathioprine, Imuran, mycophenolate mofetil, which is a very Cellcept, a very popular drug and still very much used in kidney disease. Cyclosporin, which is a calcineurin inhibitor. IVIG can be helpful. Plasmapheresis in those really sick people, and rituximab, which I've used a lot of in the past, but I don't have to use as much. And then it's tricky with rituximab because of COVID. Rituximab can block the antibody response, and I'm concerned that they won't have the vaccine, which will prevent COVID. So I'm very careful when I use this drug. Now, what was recently approved? Benlysta was approved 2011, but more recently approved for the kidneys. Anifrolumab or Safnello was approved a couple years ago. It's an IV infusion, and I find it's very good for skin, and it also helps people's fatigue. And I find that remarkable for people that have been so tired. I don't want to give them steroids because that has too many side effects. And then there's voclosporin or lupus, which helps us now with significant kidney disease. Next slide, please. So in 2011, the Food and Drug approved belimumab or Benlysta. It had innovative outcome measures. There was a 50-year need. I mean, we kept using drugs from other specialists, especially oncologists, to treat our disease. Most importantly, it had steroid-sparing effects. So it was a drug that you could lower the steroid and make the patient better. We could use less toxic medications, such as mycophenolate mofetil, azathioprine, Imuran, methotrexate, and it had a very acceptable safety profile. Next slide, please. Now, what happens with lupus? Well, in lupus, in a normal person, we have this B cell stimulator called BLyS or BAFF, and they're released from the macrophage, and they block apoptosis, which is programmed cell death, so B cells go up. Now, Benlysta, especially in a lupus patient, blocks the blocker of apoptosis, so apoptosis does occur and B cells go down. And that's basically what we're doing with this drug. Next slide, please. So, as was discussed by Ellen Ginsler in 2021, FDA approved agents for lupus nephritis. There were 2 new drugs. That was hard for a lot of us to believe. 2 new drugs, belimumab or Benlysta or voclosporin or lupus. Next slide. Now, how does lupus work? Remember, that's kidney disease. And it blocks calcineurin. And calcineurin activates T cells, and that's part of the body's immune system. It binds and stops T cells from triggering an autoimmune response. We lower inflammation in the kidneys. And there's been large clinical trials which showed that it was better and faster at preventing inflammation of the kidneys than the standard of care therapy. So this was another major advance. Next slide, please. So if you look at lupus, it's now positioned for first-line treatment in lupus nephritis, and I'll show you later, because it has a superior response rate versus the standard of care, which is usually steroids, mycophenolate. If they're more serious, they get cyclophosphamide. And it demonstrated efficacy with decreased steroids. And 80% of patients in their pivotal trial were able to get their steroid down to less than 2.5 at week 16 and 75 at a dose. It reduced proteinuria, and we were able to get the protein less than 500 milligrams. And it had improved response rates across the immunologically active classes of lupus nephritis. Very important. You know, we've had other drugs, but with this drug, we don't have the tedious job of checking blood levels, etc. Next slide. And now, how about Saphnelo or anifrolumab, which was a drug that I was very involved in with the studies. It is approved for moderate to severe systemic lupus in August of 2021. And that's near the time where Benlysta got its approval for the kidneys. And we know that it is a third therapy for lupus to receive regulatory approval since 2011, although Benlysta was first just for general lupus and then for the kidneys in recently. And we have answered some of the most common questions we receive about Saphnelo in a lot of studies that have gone on. Next slide. How does it work? Well, it interferes with type 1 interferon signature that is found in many patients. And basically, it binds to the main receptor, a protein called interferon alpha receptor that transmits signals from type 1 interferons throughout the body. and Safnella decrease these signals and improve the symptoms of lupus. Next slide, please. Now, here were drugs that were in the pipeline last year and 2023. That's a long time ago. But you can see there are a lot of drugs that are being considered. You know, some are phase 1, we're just the beginning, some are phase 2. But some of the drugs have gone through phase 3. There was a Lilly drug that was a SYK kinase and a Janus kinase inhibitor, but unfortunately it was a negative study. There's another form of a rituximab-like drug that has gone through phase trials, and obinutuzumab, I always hate to give the generic because they stumble through the beginning. And then another study, faricimab, you know, which is a phase 3 immune modulator. Next slide. And if we look at the update of the understanding and management of lupus, some of the stuff I was able to get from Dr. Michelle Petrie at Johns Hopkins. And look, January 2024. So we're talking now 2024. We're in May, it's Lupus Awareness Month. And guess what? There's more to be aware of because we now have better, more specific drugs. Next slide. Now, if you look at the organ approach to immunosuppressive, methotrexate, if people don't respond to prednisone and Plaquenil, that might be a good drug for joints and skin, although the guidelines say you could do that, or you could go to one of these biological drugs like Benlysta or Safnella. Mycophenolate or Cellcept is a very important tool in kidney disease that also can help skin and inflammation of heart and lungs. Leflunomide or Arava is used for the joints and the kidney. Azathioprine or Imuran, joint, skin, kidneys. It's safe in pregnancy, okay? And then belimumab or Benlysta, non-renal, joint and skin. And we can say the same thing about anifrolumab, that it's being used and is very, very effective. Next slide. So here you see part of the response of anifrolumab, okay? And you can see what's very, very important, and you don't have to be a scientist to look at this. This in red is patients that were getting anifrolumab, which is Safnella, and these were patients that got placebo. Doesn't mean nothing, it means the standard of care, but they weren't getting Safnella. Now, what's really important about this drug, and I was part of the original study, I was part of the 2-year extension, I really saw this. This drug, after their first dose, after 4 weeks, they can start feeling better. And here you can see that this study was published in the New England Journal 2020. So this drug can start very fast and make people feel better. It's a pretty simple infusion, 300 milligrams once a month. So it's been a great adjunct, a great tool in our toolbox to treat lupus. Next slide. Now, this is the long-term extension trial where you can see people taking this drug up to 4 years. And this is anifrolumab. And you can see, if you look at the red, at the change in the SLEDAI. Now, the SLEDAI is the SLE, Disease Activity Index, that came out in the year 2000. This improvement, which started at month 1, is persistent over those 4 years. And I found this very remarkable because these people, they always came in, they said, I'm doing fine. I don't have many features anymore. Able to get their steroid down to less than 5. able to get them off maybe immunosuppressive drugs like methotrexate, Cellcept, etc., azathioprine. Next slide. And here is some COVID data about AEs in the anifrolumab long-term extension. And right here, you can see there was one, and if you look at other data that's more updated, there were 2 deaths. But those 2 deaths were in patients that were in other countries, and they didn't get the vaccine. So I use that because a lot of lupus patients are leery of getting the COVID vaccine. I tell them, look, we've done studies, and it appears it's obviously small numbers, but certainly death is not a good outcome, that those patients that were taking, whether it be anifrolumab or belimumab, they do well and they don't get COVID, and they certainly don't die from it. So I really encourage patients to get the vaccine. And if I want to give them rituximab, which is a pure B-cell depleter, or a new B-cell depleter, I want them to get the vaccine and hope they get an antibody response so they can get this, be safer. Next slide. Now, here is another drug, and this is a type 2 inhibition, and its rationale, it binds to the JAK1 allosteric pocket. You don't have to know what these things mean, but it reduces the inflammatory cytokines, IL-23, IL-12. By the way, those are also upregulated in psoriatic arthritis. They can inhibit type 1 interferon, and that's what anifrolumab or Saphnelo did, and they may avoid some of the JAK toxicities. One of those could be a hypercoagulable state. And if you look here, you can see the response rate is the highest in the light blue. And this was another study that was discussed, and it's another type of drug that's being looked at currently. Next slide. And another drug is one that inhibits interleukin-2. And this was a small study, 12 weeks, 100 patients. And if you look at the protocol, if you look at the IL-2 inhibition versus placebo, 83% versus 52%, you can see that there's a major difference if people are giving this type of treatment. But obviously, we need much larger randomized controlled trials. But we're finding different markers and biomarkers that we can inhibit. Next slide. And here is another one, Respeg, which regulates T cells, because we have a lot of good drugs for B cells, but this regulates T cells. And you can see here, again, that people getting this drug did better, 31% versus 25% of those receiving this drug. And this is going on to be looked at in more detail in good, this is a phase 2, in good phase 3 trials that are presented to the FDA. Next slide. All right, how about other things that people ask me about? How about turmeric? And believe me, I get asked about this a lot. Now, I can't see you all, but I bet a lot of you have tried this. Now, just be aware that there are complications. It can cause gallbladder obstruction, kidney stones. It can irritate your stomach. It increases tacrolimus, which is that calcineurin inhibitor, which could cause side effects. It can affect CNS pathology in experimental lupus. And in mice, it inhibits some of the good cells that we want. Now, a lot of people try it. I don't actively prescribe it, but if they feel better, and as long as I think it's not causing problems, I encourage them to take it, okay? I think it's something that we need. If they've had a lot of CNS disease, confusion, seizures, and they say, well, I think that's getting worse, And I ask them, are you on turmeric? Because a lot of people take it. I say, well, maybe you should stop it and see if that makes any difference. Next slide. Well, this is a big one. Cannabidiol, various forms of cannabis. Now, it helps a lot of people. Now, I don't prescribe it, but a lot of people take it, whether it's for pain. Some people can get it for seizures. But one of the things we know that it accelerates proteinuria in the lupus model. So certainly people that have kidney lupus and they ask, was it okay if I take that? I said, well, if I were you, I wouldn't take it because kidney lupus is hard to treat and we don't want you to get into problems. Next slide, please. So there's a new paradigm we now have for lupus, and whether this is lupus in the kidney, which this talks about, or general lupus. After they get their prednisone and after they get maybe a low dose of methotrexate, azathioprine, the guidelines are saying, instead of using the immunosuppressive drugs, maybe you can go to one of these new biologics like Benlysta or Safnello. And I found in these patients, we don't need to give them those drugs. And the same thing in the kidney now is if they have a biopsy, we use the conventional treatment. CNI is a calcineurin inhibitor, such as tacrolimus. And then belimumab has been listed. If they're still active, we can use 3 drugs: cyclophosphamide, the calcineurin inhibitors, or Benlysta, because as you know, it's FDA approved. So we're sort of being more aggressive in the beginning to prevent progression. Next slide, please. And in the lupus nephritis trials, which I was very much involved with, you can see the primary efficacy of response was 43 versus 32. Next slide. And here's another drug that is it's like a rituximab. It's humanized and built. People do better. So we will have this drug, and you can see people with nephritis did better. Next slide. And this is the data on LUPKINase, showing how it got more people in either partial or complete remission. Next slide. And we'll go on to the next slide. And again, this is being studied in a long-term extension, and there's also a sub-study, and the biopsies showed no nephrotoxicity. Next slide. So we're back to the beginning. And here we are back with Bill Murray and Scarlett Johansson. 2 things. They're no longer at the bedside because we've been able to translate these biological drugs into treatment, and they really work. Remember what I said in the beginning. People now come in and say, Dr. Newell, I'm so much better. And these may be people that I followed for 20, 30 years, and I was sort of at an impasse, and I didn't want to give them more Depo-Medrol or more steroid. So here you see Bill Murray and Scarlett Johansson. And lupus treatment with the tools that we have in our toolbox are no longer lost in translation. A lot is happening, but to tell you the truth, they look very tired because they put in a lot of work trying to make these drugs work, trying to have the right protocols. But I think we're getting there. We're getting closer. And I think we're going to be of the era where we have lots of drugs for rheumatoid, lots of drugs for psoriatic arthritis. And pretty soon, over the next couple of years, we'll have lots of drugs to treat lupus and subsets of lupus as we look at it. And with that, I'm going to leave you. You don't want to have lupus, but if you have lupus, this is a good time to have it because we have lots of treatment. We have more educated doctors that know how to use these drugs. Thank you very much. And I want to thank the Lupus Foundation of Northern California for asking me to give this lecture. Now, I guess I will open it up to questions.
Thank you so much, Dr. Newell. That was really interesting. A lot of great information. We do have a couple questions here in the Q&A. Somebody says, can you touch on dysautonomia and lupus? How common? What are the symptoms, etc.?
Well, these are discrete neurological syndromes. And a lot of these have been seen in lupus, and they're put under the spectrum of neuropsychiatric lupus. And many times, if a patient has lupus and has an illness such as that, they'll respond to the treatment we use for lupus. But, that's a very rare case. And obviously, we don't have randomized controlled trials for neuropsychiatric lupus in general, so we certainly don't have it for dysautonomia, but we do have case reports. Okay.
Thank you. And the next question is, can I use Benlysta, vocalosporin, or lupus if my transplanted kidney is failing?
Oh, I think absolutely. I think that it's a third drug. And, you would have to ask a transplant specialist, but certainly lupus is a calcineurin inhibitor, which they use in lupus transplant patients. You could use that. And if the kidneys are failing, I think you could use Benlysta. But I would leave those decisions up to your transplant doctor, because, we don't have data about that. But it makes perfect sense to me that you could use it.
Sounds great. If anyone else has any questions, please feel free to chime in. You can put it in the Q&A section or in the chat. One other question is, Dr. Newell, you were showing the, excuse me, the criteria for a lupus diagnosis. And I'm wondering if somebody doesn't have all the criteria for a diagnosis at that time, what do you usually do with them as a doctor? Are you still able to treat them?
Well, there's several terms, but I think one of the terms that I think is the most important is incomplete lupus. I mean, somebody comes in and they have a classic malar rash, spares the nasolabial folds. They have a lot of hair fall with diffuse and focal, and they have polyarthritis, but they don't meet those criteria. I call those people incomplete lupus, all right? I treat them, usually low-dose prednisone, hydroxychloroquine, but certainly if that patient wanted to get into a clinical trial, they couldn't, because they don't meet the classification criteria that are needed for studies. But I would treat those people, and I think the most common thing I use is incomplete lupus. They don't quite have it, but I certainly go ahead and treat them if I'm really convinced this is part of the lupus spectrum. And I think a lot of those patients, unfortunately, don't get treated because people think they have fibromyalgia, et cetera, and they don't get treatment for their incomplete lupus.
Yeah. Okay. Thank you for that. That's helpful. Do you see an increase in bacterial infections in patients on MMF and Safnello? Somebody wants to know.
Well, I would say that any of the immunosuppressive drugs, any of the biological drugs, and it's so nice to say that now that we have 2 biological drugs, can increase the incidence of infection. So, we're very careful. I always, I check their blood. One of the things we do, we always check for hepatitis B, hepatitis C, and do a quantiferin for TB. And I also get a full urinalysis because I want to make sure they don't have a positive urine culture. Because if they had a urine infection and they didn't know about it, I'd want to treat that. Yes, people can get infections, but the efficacy of the drugs is far greater than the slight increase in infections. But remember what I said, when I work up a lupus patient, the first 9 things in the differential is infection, and infection can trigger active lupus. So I want to treat that infection.
Yes, that makes sense. Another user here says, I speak to a lot of African American women who suffered from lupus, but the doctors refuse to check them for the disease for years. What can they do to advocate for testing if a doctor refuses?
Well, I would say if a doctor refuses, he would have to have a good reason, especially a young African American female. And I would be persistent, or I'd go see another doctor. I mean, again, that subset of patients that gets the most lupus are young African American females, and especially if there's a positive family history. I mean, to refuse, I don't quite understand that. It's you get that Hep2 substrate of the ANA, it's one blood test. And I guess they're concerned it'll lead to confusion, but if you want it, you should be able to get it.
Yeah. I'm going to just ask this last question in the interest of time. And if there are other questions, please feel free to send them. And then we'll ask Dr. Newell if that's okay and send them out in an email format for
Okay, no problem. Yeah.
Okay. So the last one is someone says you talked a lot about women and lupus, especially regarding hormones. How is this comparable with men?
Well, in men too, I mean, in men, there's increased testosterone levels. And sometimes in lupus, men want to take testosterone. And I think I showed in one of the slides, in women of testosterone can perhaps aggravate lupus. And I think if I had a male with lupus, and sometimes when men get lupus, it can be worse. I discourage them for taking things like testosterone, especially if they had kidney disease, et cetera, because I think it could lead to aggravation of their disease. It just depends. Again, it's an individual case of what they're trying to treat. And, we sort of make a decision together between the patient and myself about what the best course of action is.
Yes. Okay. Thank you so much, Dr. Newell. We really appreciate your time today and your expertise. It was a joy to have you here.
All right. Thank you very much. And again, thank you for asking me.
Our pleasure. Yeah. So now we'll go ahead and welcome our 3 patients for the patient panel discussion. So welcome Robin, Rachel, and Indy. And before we begin, remember if you have any questions, you can type it in the Q&A at any time, and we'll ask at the end of the session. Now, if, let's see, are our ladies here?